Welcome to The Explainer. Today, we're opening up a medical case file on an invisible condition that's literally hiding right in plain sight. We're going to take a really close look at hypertension, breaking down exactly what it is, who it affects, and how we can actually fight back using clinical data and expert insights. So let's just dive right into it.
Medical professionals frequently call hypertension the silent killer. And honestly, there's a pretty chilling reason for that nickname. It can quietly damage your body for years, sometimes even decades, without showing a single outward symptom. You could be walking around feeling absolutely perfectly fine, while your cardiovascular system is secretly under immense strain. Crazy, right? To really understand the massive stakes of what we're looking at today, consider this number, 13. Back in 2017, hypertension was ranked as the 13th leading cause of death, and that rate has just been steadily climbing year over year. So we're not talking about a minor health inconvenience here. We're dealing with a major primary risk factor for cardiovascular disease, kidney failure, and stroke. Here's our game plan for today. We'll start with the mechanics of pressure, move on to profiling the risk factors, explore the medical arsenal we have to treat it, and finally, look at how you can take back control.
Section 1. The mechanics of pressure and understanding blood pressure.
All right, let's break down the physics of our biology. It really helps to think of your blood vessels like the plumbing in a house. The pressure inside those pipes is naturally going to increase if a few specific things happen. First, if the heart pumps harder, which is your cardiac output. Second, if the blood itself gets bigger, that's viscosity. Third, if the sheer volume of fluid increases. And finally, if the vessels themselves lose their ability to stretch, which medical experts call peripheral vascular resistance. If any of those factors fall out of balance, the pressure goes up, and those pipes really take a beating.
That plumbing analogy perfectly sets us up to understand those numbers you always hear at the doctor's office. Blood pressure is read through two distinct measurements. The top number is your systolic pressure. That measures the active pumping contraction of the heart, basically the moment of maximum force. The bottom number is your diastolic pressure, and that measures the expansion and resting phase between those beats. Both of those numbers are absolutely critical pieces of the puzzle.
The American Heart Association breaks these readings down into specific categories. A totally normal reading is less than 120 over less than 80. Anything above that starts to indicate an escalating risk. Once you hit stage 2, which is 140 or higher for systolic, or 90 or higher for diastolic, you're at a significantly higher risk for target organ damage.
Moving on to Section 2, profiling the risk factors and what actually causes that rise.
So, medical experts divide risk factors into two main camps. On one side, we have non-modifiable factors. These are things we just can't change, right? Like our age, our genetic family history, and our ethnicity. But on the flip side, we have modifiable risk factors. These are the elements totally within our control. We're talking about managing blood glucose levels, not being completely inactive, quitting smoking, dialing back on salt and alcohol, and, surprisingly enough, making sure we get more than 5 hours of sleep a night. A lack of sleep is actually a massive, often overlooked trigger for hypertension.
Now, when we look at the demographic data, we see that the prevalence of this condition really varies. It affects 54% of non-Hispanic Black adults compared to 46% of white adults, 39% of Asian adults, and 36% of Hispanic adults. Interestingly, research notes that hypertension among Black individuals is often tied to increased renin activity, which essentially causes a greater retention of sodium and fluid in the body. Understanding this biological difference is actually super important because it helps providers choose much more effective, targeted medications.
Let's ground all this in reality with a quick medical case. Consider Ms. Diaz. She's a 54-year-old office manager, and her lifestyle hits a bunch of those modifiable risk factors we just talked about. She smokes, deals with high stress, eats a lot of fast food, and drinks alcohol daily. She came into the clinic complaining of what seemed like a minor symptom, morning headaches. Well, since hypertension is usually silent, those headaches could actually be a major warning sign of what we call a hypertensive urgency.
That brings us to a crucial point, understanding the difference between a high reading and a full-blown medical crisis. When blood pressure spikes dangerously high, providers have to distinguish between two states. The first is hypertensive urgency. That's where pressure is high, but there's no immediate progression of organ damage, and it can usually be treated with oral medications and close follow-up. But a hypertensive emergency? That's when readings soar past 180 over 120, and there's a direct, immediate risk to target organs like the brain, the heart, or the kidneys. That requires instant intervention in an ICU, usually with IV meds, just to prevent organ failure.
Section 3. The medical arsenal, how we combat the killer.
The good news is, our medical arsenal is wonderfully vast, and it directly targets those plumbing issues we talked about earlier. Diuretics act sort of like a release valve, helping the kidneys increase urine output to flush out excess sodium and fluid volume. Beta blockers step in to decrease the heart rate and the force of its contraction. ACE inhibitors stop the production of a potent vasoconstrictor, which allows the vessels to just relax. And calcium channel blockers, they stop calcium from entering cells, leading to vasodilation, or the widening of the blood vessels.
But we definitely have to acknowledge a harsh reality here. These are lifelong medications, and they can come with some deeply frustrating side effects. Patients might deal with severe fatigue, a persistent new cough, or erectile dysfunction. They can also cause orthostatic hypotension, that really dizzy feeling you get when you stand up too fast. And because hypertension itself usually doesn't have symptoms, these side effects can sometimes lead patients to mistakenly think the medicine is actually making them sick, which unfortunately causes some folks to just stop taking their life-saving prescriptions.
Let's look at another clinical case to see how these side effects can really impact someone's daily life. Take 80-year-old Mrs. Bell. She's on diuretics, which causes nocturia, meaning she makes frequent trips to the bathroom during the night. Now, when you combine those urgent nighttime trips in the dark with the dizzying effect of orthostatic hypotension, her poor vision, and throw rugs in her hallway, you create a severe, highly dangerous fall risk. So medical care really isn't just about prescribing pills, it's about holistically managing how those pills affect a patient's entire life and safety.
Which leads us perfectly into Section 4, taking back control through lifestyle interventions. A major tool in this fight is nutrition. The dietary approaches to stop hypertension, usually just called the DASH diet, is clinically proven to lower blood pressure. It does this by sharply restricting sodium while hitting some very specific daily serving targets. The emphasis is on 6 to 8 servings of whole grains, plenty of fresh veggies and fruits, and keeping lean meats to 6 ounces or less a day. The evidence here is super clear. Even small dietary shifts can massively reduce your cardiovascular risk. To help make all these daily habits stick, medical professionals use a brilliant little mnemonic, LIFESTYLE. L stands for limit salt and caffeine. I is to include daily potassium. F, fight fat and cholesterol. E means exercise regularly. S, stay on your BP regimen. T, try to quit smoking. Y, your medications taken daily. L, lose weight. And E, end-stage complications will be avoided. It is honestly the perfect mental checklist for daily management.
Okay, listen up, because if you take absolutely nothing else away from this explainer, this is the absolute most crucial takeaway. Even if you feel perfectly fine, and even if your numbers look fantastic today, you must never, ever stop taking your medications unless directly told to do so by your healthcare provider. Hypertension is managed, it's not cured. Stopping abruptly can cause incredibly dangerous rebound spikes in your pressure.
So, we've pulled back the curtain on this invisible condition. We've unmasked the silent killer, explored its underlying mechanics, and mapped out a solid clinical blueprint for defeating it. The science gives us all the tools we need, but at the end of the day, the execution is entirely up to us. So the only question left for you is, how will you take control of your numbers?